Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. And a very good morning to everyone. Thank you for joining me today. Okay. First, this is the outline of our lecture today. Okay. First, just a quick lecture on medical clerking and general respiratory examination. First of all, as any other examination or clerking, any system actually, you need to create a good rapport with the patients. So put a smiling face, be polite, okay. And next, you need to address the chief complaints of each patient so that you can formulate your differential diagnosis depending on what the patient is complaining. Okay, complaints can be the ones that makes the patient comes to the hospital. It can be also complaints that has been there for a while, but the patient does not perceive it as that bad, so that they don't have to come to the hospital. But it is worth getting into this sort of secondary non-chief complaints. Okay, you get what I mean? So need to address that. Always ask the patient, is there anything else is bothering him or her? Okay, things that doesn't make him or her comes to the hospital but has been bothering them for some time. Okay, next is when you ask questions, it should be open-ended but focused. What do I mean by that? Is when you ask the question, you need to try to make the patient answer in his or her own language or in own version. Okay, for example, if the patient complains of prolonged cough, you can start with the question, boleh tak pakcik ceritakan sendiri macam mana batuk tu terjadi? Apa ataupun pakcik boleh cerita tak macam mana masalah batuk pakcik ni? When I say focused, it means that when the patient starts to ramble or saying things like unrelated to the chief complaint, so you need to pull the patient again towards the earlier question, but do it politely. Okay, so as you see in this slide, I put in the Socrates. Most of you will remember that Socrates is the mnemonic that you use to clerk a patient about pain. So actually, you can use this as well to go into detail of any complaints or any symptoms. For example, you have a patient who complains with prolonged cough. Okay, so as you remember, the S is for sight, but since you are trying to explore about the cough, S is not applicable. O, as you all remember, is onset. So you can apply this to cough as well. So ask, when does the cough starts? Okay. Next is your C, which is the character. So you can apply the character of cough by asking, how can you tell me what is the character of the cough? Is it chesty? Is it dry? Okay. Radiation, R here, is how to say not applicable for cough. All right, so that won't apply. A is your association. So ask the patient, is there anything else that associates with the cough? For example, is there any pleuritic chest pain, or is it there any hemoptysis? Anything. Okay. T is your temporal relation or time. So ask the patient, when does the cough gets worse throughout the day? Is it night? Is it day? Is it morning or evening? Okay. E is your exacerbating relieving factor. And lastly, S is for severity. Ask the patient, how bad is the cough that makes you comes to the hospital, or how bad is the cough at home? Okay. So you need to ask that. Next, you need to ask the patient's perspective. So how to ask patient perspective is to have the ICE, ideas, concerns, and expectations. Sorry. So next is about patient's perspective. So you need to have the ICE, ideas, concern, and expectation. So what do I mean by ideas is you need to ask the patient what does they think of their disease? What do they think they have? For example, patient comes with cough, he or she might think that they have cancer. Okay, so they need to have a checkup, right? So next is concern. Why does the patient is so concerned with the symptoms? Is it causing him or her having difficulty at job? Is it that the cough makes them to have problems at home with their spouses? Okay. Next is your expectations. If you need to ask a patient, what do they expect from the doctor when they come to the hospital with that complaint? Is it that they want some treatment, or is it that they just want some attention or clarification? Okay, this is very important that when a patient comes to you, when you start offering treatment, they might not agree to that treatment. So you need to have a knowledge of the patient's expectations. Okay. Next is your social history. This is the mnemonic I use every time I clock a patient. So has HD. S is for smoking. O is for uh, occupation. A is for alcohol. P is for pets. H is for hobbies. A is for activities. T is for travel. S is for sex or sexual promiscuity. H is for home. What do I mean by home? Is the home's location, the condition at home, the electricity, the water supply. Or some of you may include who's at home with the patient and financial income, whatever. All right. So next is your D. D is your drug abuse. Okay. Sorry. If you don't mind, I would have some tea during this presentation. Okay. So lastly is your adherence and correct application of treatment. This is very important, especially in respiratory diseases whereby we have lots of devices or inhalers. So you need to have some idea about the treatment used in respiratory diseases and how to apply them, especially for inhalers. All right. That's all for medical clerking on general respiratory examination. So next is our crux of today's lecture, which is the physical examination. So this is the steps that we use in physical examination. This has been taught by Prof. Emeritus Mustafa Embong. He was our old HOD and the Dean of PPSP before. So the steps stated here. Step 1, introduction. Step 2, preparation. Step 3, examination. Step 4, conclusion. Followed by step 5, presentation, formulation of a diagnosis, confirmation of investigation, and lastly, pass the exam or complete the physical checkup. Okay, so what I'm highlighting in this box is the 4 initial steps of physical examination. Okay, whereas the remaining 4 is when you are presenting the findings of your physical examination. So we are going to concentrate on these first 4 steps, which is the introduction, preparation, examination, and lastly, conclusion. So first step 1, which is introduction. So you need to introduce yourself. If you have an examiner by your side, you need to introduce them as well. State the purpose of the examination to the patient, and lastly, ask for permission. I need to emphasize to everyone that your voice should be loud enough to be heard by the examiner. Because in exam, if you talk so slowly that the examiner couldn't hear you, they might think you are asking answers from the patient. Okay, so be loud enough, but not too loud to startle everyone in the room. Okay, so next is preparation. So prepare yourself first. Actually, you need to equip yourself with the necessary equipment, and you need to position yourself. So at the start of the examination, you need to position yourself at the end of the bed. And before that, actually, when you introduce yourself and the examiner, you should be on the patient's right hand side. So start with the right hand side of the patient and followed by the end of the bed. Next is you prepare the patient. Okay, you need to adequately expose the patient. If the patient is a female, you need to ask for permission. If the patient is shy, you can tell them that you will expose one part at a time. The other part will be covered immediately. And next is you need to position the patient adequately. As you see in the video, you can do the respiratory examination at 45 degrees supine or in a sitting position. Only these two position. No supine 180 degrees. Okay, next is step 3, examination. So the examination is divided into 3 levels. The first is your general examination, followed by systematic or peripheral examination. I prefer using the term peripheral examination. So to let you not confuse between general and systematic. Okay, so after that, level 3 is the specific examination. Okay, I think most of you have already seen this table inside my video. These are the 4-3-2 rules that I have been taught by Prof. Emeritus Mustafa Umbung. So it consists of the initial 4, which is the consciousness level, rationality or orientation, uh, pain status, or whether the patient is restless, appears restless or not, followed by the nutrition, hydration, and coloration. Last is extension or attachment, and next is gross abnormality or deformity. Okay, so all these are seen at the end of the bed. I repeat, at the end of the bed. So you spend some time, maybe about 10 seconds or so, to look for this. Okay, so maybe some of you think that you can also detect jaundice, palocyanosis from the right hand side of the bed. Yes, you can do that, but this is how to train yourself to have some idea before you move in closer to check the patient. Okay, remember these 4-3-2 rules. About attachment is anything that is attached to the patient, such as branula, nasal prong, oxygen supplementation, continuous bladder drainage, anything that is attached to the patient. Blood investigation, CT scans, whatever, it is not considered attachment to the patient. Okay, except for example, you have a cardiac monitor attached to a patient, that is considered attachment. Okay, all right, same thing as well. I've told you earlier. Okay, so consciousness level you can just describe as fully alert or drowsy, stupor or coma. Rationality, quickly you can assess using the Glasgow Coma Scale or GCS score. And pain, whether the patient appears in pain or not. And lastly, whether the patient appears restless or not. Okay, same thing as well. Next part of the 4-3-2 rules is the nutrition, hydration, and coloration. Remember the red, yellow, and blue. Remember these 3 colors: red, yellow, and blue for the color status of the patient. Alright, next is the external abnormality, attachments, gross abnormality, deformity, or patient's position at the time. Patient may be lying in a tripod position in respiratory failure. Okay, patient may be lying prone, for example, but you rarely see that in the ward. Next is your level 2 or systematic slash peripheral examination. So what I'm showing you now is the railway track. Okay, I repeat, railway track, landasan kereta api. So any examination, you start at one point. Once you finish with that point, you move on to the next point or the next station. Okay, so your systematic or peripheral examination starts with the hand, followed by the wrist, arm, neck, head. As you can see, there is other unlabeled dots here. This indicates the systematic examination. No, sorry, specific examination of any system you are interested to examine. For example, if you are examining the respiratory examination, maybe this can be the um, inspection of the chest wall followed by palpation and so on and so forth. And lastly, remember always to check the patient's gait. Ask the patient to stand up and walk. This is in applicable in clinical practice, not in exam. So in exam, usually you don't end with gait. All right. Usually you just examine the lower limbs. So quiz time. Oh, okay, about time. So please log on. Okay, now we move on to the quiz. So answer fast to get more points. Which one is not part of the 4-3-2 rules? A. Hydration. B. Coloration. C. ECG. D. Obese. So make your choice. Okay, very good. Everyone answered ECG. So ECG, as I told you earlier, is not an extension to the patient. However, if the patient is attached to a cardiac monitoring, it is considered an attachment. All right. Why I say so? Because ECG is only a temporary monitoring of the heart rhythm, whereas what cardiac monitoring is continuously monitoring the cardiac rhythm. All right. Moving on to the next quiz. Question 2. Answer fast to get more points. Which one is an example of extension? Full blood count, nasal prong, computed tomography of the brain. If any of you are clueless, you can always pick the longest answer. Okay, please don't take me seriously. 3, 2, and 1. Yep, someone got fooled and answered computed tomography of the brain. So computed tomography of the brain is just CT brain. CT brain is a radiological examination of the brain. It's a one-off examination. So it's not an extension of the patient. All right. So nasal prong is something that's attached to the patient most of the time. So it's considered an extension. Full blood count, same as well as CT brain is a one-off monitoring or evaluation of the patient's blood cell counts. All right. Okay, that's my daughter just now. She's bothering me. Okay, so we are changing back to our lecture. So hopefully you are still logged on to your phone. Yeah. Okay. So step 3, as I told you earlier, you examine the hands. So as you see in the video, you need to ask the patient to stretch the hands straight forward. Okay, and also for any evidence of flapping tremor. Okay, you can also see fine tremor as well. On top of that, you should look for any cyanosis, and you need to examine for finger clubbing. I will be explaining after this. And next, wasting of the small muscle of the hand. This is better evaluated on the dorsal part of the hand. You can see the guttering of the small muscles of the hand better, okay, compared to the palmar side of the hand. I will show you an example of an image later. So finger clubbing, you have 5 grades. Grade 1 is fluctuation of the nail bed. Grade 2 is the loss of the Lovibond angle. Normal angle should be more than 100, less than 165 degrees. And then you have your Shamross window obliterated. Normally you will have a Shamross window. How you get the Shamross window is like this, shown in this picture. Number 2, you oppose the dorsal part of the finger, so you will see a gap between these two fingers. So this is called the Shamross window. As you can see here, the Shamross window is obliterated. On top of that, the nail also appears clubbed because of the loss of the Lovibond angle. So this is a example of a normal Lovibond angle. Okay. So if you see the angle is flat, then it is clubbed. The finger is clubbed. Picture number 1 is showing how to evaluate the nail bed fluctuation. Okay. So I need to remind everyone that in normal population, you will have finger clubbing as well, meaning that they have finger clubbing, maybe grade 1 or grade 2, but the patient may not have any diseases. So keep it in mind. All right. But for grade 3, grade 4, and grade 5, which is rarely normal in the normal population, so you need to think of diseases related to finger clubbing, such as lung diseases or liver diseases or cardiac diseases. Okay, I won't be explaining on the diseases causing finger clubbing in this lecture. You can read up on your textbook. Okay, so grade 3, grade 4, and grade 5 is easily detected, is easily assessed even at a glance. So I need everyone to really evaluate the grade 1 and grade 2 finger clubbing, which is easily missed even for experienced clinicians. So you need to look closely at the patient's fingers. Okay. So this is an example of finger flapping tremor. Okay. As you can see, there is intermittent flapping or palmar movement, flexion of the hands. And the doctor just now did a enforcing maneuver, okay, to show the flapping tremor better. So flapping tremor is not a tremor itself, it's actually a myoclonus due to CO2 narcosis, due to hepatic encephalopathy. Okay, so that's an example of flapping tremor. So this is an example of cyanosis. As you can see, it's glaringly purplish. If you are unsure whether the patient is cyanosed, you can compare your hands with the patient's hand. All right. Okay, this example of wasting of small muscles of the hand. On the right hand side is the wasted tena and maybe hypotena, but the tena is more prominently wasted compared to the left hand. This is an example of guttering of the hands, okay, compared to the right hand. Okay, so next is once you're done with the hand examination, you move on to the wrist. So what do you assess at the wrist? You assess the pulse. You need to assess the rate, whether there's tachycardia or bradycardia. Assess the character. Is it bounding? So in respiratory examination, usually you will get bounding pulse, which can be due to CO2 retention or sepsis. Pulses paradoxes is something you may have read in your textbook, but in reality, including me, I've never actually assessed it in any patients. Okay, because it's time consuming and it's very how to say difficult to do, especially in unstable patients. Okay, you can assess these conditions with other physical examination other than assessing the pulses paradoxes. Okay, next you move on to the arm, you check the blood pressure. Okay, after you finished your arm, and then you move on to the neck. So you check for the JVP, then you check for the lymph nodes. If you recall my video, I've checked the lymph nodes at the end of my physical examination. So looks contradicting. However, it depends on the doctor or the clinician on how they want to do the physical examination. If they are comfortable doing the lymph nodes at the early part of the examination, fine, it's okay. If they are comfortable doing the lymph node examination at the end of the physical examination, it's okay as well, as long as you do it. All right. So when you're done with the neck, you move on to the head and face. Look for facial puffiness, dilated neck veins, and look for any feature of pink puffer or blue bloater. These are textbook definition. Nowadays is never being used anymore because you can have a mix of pink puffer and blue bloater. Okay, so pink puffer and blue bloater, if you all recall, it is a condition associated with COPD. Okay, next, eye examination. You look for Horner syndrome and you look for chemosis. I don't have an example of Horner syndrome images or video. You can look up online. It's very easy. The hallmark of Horner syndrome is the partial ptosis. I repeat, partial ptosis. So you need to differentiate between complete ptosis and partial ptosis. There's a difference between these two. That's a clue for you to read up later. Right? Chemosis is the appearance or swelling of the eyeballs due to edema. Right? So is assessment of the lower limb to look for pitting edema. So when you detect a pitting edema, you need to look for the extension of the edema. How high does it go? Does it reach the knee, or is it just mid-shin, or is it just ankle? Right? So you need to know the level. And always remember that start at the lowest part of the leg, which is your ankle, and press over the bony prominence, not the muscles. Okay, I repeat, press on the bony prominence. And also look at the patient's face. If you might cause pain to the patient. If the patient wins or showing you any sign of pain, you need to withdraw immediately. Okay. And one more thing, as you all remember in my video, I checked the patient's limb, the lower limb at the end of the physical examination. That's my style. If your style is lower limb examination early on, it's okay as long as you do it. Next is the specific examination. So for respiratory examination or any related physical examination, you use the look, feel, tap, and listen method. So what do I mean by look? Look is inspection, feel is the palpation, tap is your percussion, and lastly, listen is for auscultation. So for inspection or look, you count the respiratory movement. Okay, maybe some of you will do this on as you do this on in the physical examination. In my video, I counted the respiratory rate while after I checked the radial pulse. Okay, so if you already done the respiratory rate, you can skip it. Don't do it for the specific examination. So other thing that you look in the specific examination is the use of accessory muscle and the breathing pattern. Accessory muscle is sternocleidomastoid and your scalene muscles and your abdominal muscles. Okay, breathing pattern are these. So I won't go into detail about this because not all breathing pattern can be encountered in your clinical work. So you have eupnea, tachypnea, bradypnea. I don't have a example video for all these. Okay, so usual ones you will encounter is tachypnea. You will encounter cosmal breathing here. Okay, and maybe you will encounter chain stokes. Okay, chain stokes and beyond is how to say very hard to differentiate. It looks almost the same clinically. In a clinical situation, we cannot differentiate between these two, chain stoke and biots. So it's good to know, but no need to how to say go into detail about this. Right? You just need to know diseases that cause small breathing and diseases that causes Biots or chain stop breathing. Okay, moving on to other part of inspection. Okay, so other than looking for use of accessory muscle, you need to grossly have a look at the chest wall configuration. So what do you look for? Symmetry of the breathing. Okay, sometimes it is glaringly obvious. Patient chest is mengembang. Okay, and when on inspiration without doing the chest expansion maneuver. Okay, next you look for the AP diameter. Normally it should be 2 to 1. If you have a close 1 to 1 diameter, means that the patient is having barrel chest. So I show you an example after this. Other abnormalities of the chest wall are pectus excavatum, pectus carinatum, and barrel chest, like I mentioned earlier. Look for any scars, little chest. There's a video after this I will show you, and also presence of dilated veins, which may suggest venous obstruction, superior vena cava obstruction. This is an example picture of dilated veins. This is a patient with a lung tumor causing superior vena cava obstruction. This is an example of the pectus carinatum. Pectus excavatum. Pectus excavatum. All right. So next is your pectus carinatum. Okay, excavatum. You remember excavator? The apa tu jentera excavator tu, it digs up the patient chest wall. So pectus excavatum. Okay, hopefully you understand that. Carinatum is pigeon's chest. So carina. All right. The carina is a word derived from the bird. So this is an example of barrel chest. As I told you earlier, in normal population, the ratio should be 2 to 1. Means that the AP diameter is wider compared to the width is transverse diameter is wider compared to the AP diameter. However, in barrel chest, the ratio is almost 1 to 1. Okay, this is a common finding in patient with emphysema. So this is an example of flat chest. Pay attention on the patient's right chest wall. As you can see, when the patient inspires, the chest wall recesses into the body. So this is because of trauma, resulting in multiple rib fractures. Okay. Next is your palpation of the trachea. So we need to pay attention whether the trachea is pushed or pulled, depending on the pathology. So in normal population, trachea will be slightly deviated towards the left side. I repeat, slightly deviated towards the left side. So if you detect a trachea deviation towards the left side, it may be normal. So you need to relate with other physical findings. Okay. So quiz time. Okay. So answer first to get more points. We are 9 a.m. already. Which one does not indicate finger clubbing? A. Presence of shamross window. B. Drumstick appearance. C. Loss of Lovibond angle. Okay, make your choice. 5, 4, 3, 2, 1. Okay. Alright, so most of you got it right. So if you detect shamross window, means that there is no finger clubbing. Okay. However, as you all recall, shamross window can still be present at grade 1 finger clubbing. So you need to assess the fluctuation of the nail bed. Okay. Answer first to get more points. Trachea deviates towards the affected lung in, remember, towards. Okay. A. Pneumothorax. B. Lung mass. C. Lung collapse. So make your choice. Sorry, this one counted a bit fast. I forgot to change it. All right. Okay. So sorry, I think I didn't explain earlier during the earlier slide. So you need to remember whether there's a pulling effect or pushing effect. So for a pulling effect means that the trachea will be pulled towards the affected side. So what causes the lung to be pulled? It can be due to lung collapse. It can be due to lung fibrosis. Okay. So what condition that causes lung to be pushed away from the affected side? So anything that causes a mass effect. So I repeat, mass effect. For example, pneumothorax causes a mass effect. Why? The air is filling up the pleural space, moving the mediastinum and everything away from the affected side. You can also have uh, a mass effect in lung mass and also pleural effusion. Okay, so almost half of you got it right. Moving on to your presentation. Next will be a palpation or feel. So always remember to ask the patient any pain before you touch or do any maneuver or press on the patient's chest wall. Okay, as you remember in the video, you need to grab as much as possible the sides of the patient's chest wall. Okay, I repeat, grab as much as possible and then you oppose the thumbs so that if you do it properly, you will get the full expansion of the lung. If you do it improperly, you just grab it a bit, so you won't get the full extent of the lung expansion. Okay, so I won't go further into that. Okay, so vocal parameters or tactile parameters, you can use your palms, use your ulnar surface of the hands. I prefer using the palms because it is more sensitive. You apply a larger surface area of your hand so you can detect the vibration better. Or if you are expert, you can use the size of your hands. Okay, why do we use 99? Because the vibration produced by the sound of 9 is more obvious compared to other sounds. Why 90? Why not 99? The T, 90, T to at a pause between these two vibration, the 9 and 9. So you have the 9 T, the T is a pause and the 9. So you can appreciate the vibration better. Okay, if think that patient have problem in pronunciating English words, it's okay, don't worry. Even pakcik dari kampung mana-mana pun, makcik yang you think very illiterate about English can say the word 99 easily. Just repeat it twice. Trust me. Senang saja. Pakcik sebut 99. They might think apalah doktor ni tiba nak ajar bahasa Inggeris. Just say it again. Pakcik sebut 99 and the patient will say it easily after that. Don't worry. You can use the word 99. Okay. So in assessment of vocal parameters, you need to know whether there is a decreased or increased. Okay. So you need to assess the symmetry or compare left and right, up and down. All right. So causes of reduced vocal parameters are obstruction of transmission, bronchitis, emphysema, and pleural effusion. Diseases, conditions that can cause increased vocal parameters are consolidation and mass. Okay. Next is your percussion. This I really emphasize everyone to practice always. Okay, don't practice before exam. Start practicing now on doing the proper percussion. So always remember, you need to apply the percussed hand firmly on the patient chest wall. Okay, and when you strike with your other hand, you need to use the wrist movement. Okay, start practicing now. Okay, so where do you percuss is a crossing over and downward manner. All right. So in this picture, it doesn't show on the clavicle. So why do we percuss the clavicle? Is to elicit pain, not to listen to the sound. So when you do percussion, compare the sound. Appreciate the sound. Whether it's normal, resonant, is it dull or stony dull? Okay. So how to appreciate dullness on your body right now is by percussing your chest. It will cause resonant. You will hear resonant on your body. If you percuss on your thigh muscle, it replicates the dullness. If you percuss on your kneecap, it will sound stony dull. So I repeat, lung is resonant, thigh is dull, and kneecap is stony dull. Okay, you can practice the things I've taught you later. All right. So as I mentioned earlier, you need to appreciate resonant, dullness, and stony dullness. Okay. So I won't go into further on this slide. You can read it later. I will upload this on e-learning. So common pitfalls of percussion is using elbow or finger movement instead of wrist during striking. And most commonly, doctors will forget to percuss over the liver and heart. So why do we need to percuss over this? Because we want to check whether there is normal cardiac dullness and normal liver dullness. If there is resonance over the cardiac and liver area, it means that there is emphysema. I repeat, if there is no cardiac dullness and liver dullness, it means emphysema, right? Okay, quiz time. Start countdown. Okay. Answer fast to get more points. Vocal resonance is reduced in, I think it's vocal fremitus. Okay, vocal fremitus, yeah? Vocal fremitus is reduced in consolidation, lung collapse, or pneumothorax. Make your choice. Vocal fremitus or vocal resonance involve sound vibration transmitting over your chest wall. When you have something in between the lung and the chest wall, you will have a reduced vocal resonance. For example, if you have a pleural effusion, pneumothorax, you have a layer of something between the lung and the chest wall. So you have a reduced vocal resonance and vocal fremitus. As you all remembered your basic physics, in sound wave travels better in liquid and solid compared to air. Okay, sound travels better in liquid or solid better than air. So if you have consolidation or lung collapse, you will have increased vocal resonance. Why? The lung is filled with something else other than air. In consolidation, it can be pus, it can be fluid, it can be blood. Whereas in lung collapse, the lung is devoid of air, so it's deflated. So it's just purely lung parenchyma, lung tissue only, no air. So you will have an increased vocal resonance or vocal fremitus. Okay, next question. Yeah, right. Answer fast to get more points. Dullness is detected in the following except pleural effusion, lung collapse, lung mass, or pneumothorax. Make your choice. Dullness. Dullness is detected except yes, most of you got it correct. It is pneumothorax. So pleural effusion causes stony dullness. Lung collapse and lung mass causes dullness. Pneumothorax causes hyperresonance means that if you compare the lung which has pneumothorax, it is more resonant compared to the other lung which doesn't have pneumothorax. Okay, so moving on to our slide. Next is auscultation. You need to listen at the following points, the same part where you percuss the patient. So remember, we need to position the patient at 45 degrees supine or sitting. You can ask the patient to breathe through the mouth to accentuate the breath sound better. Okay, so what do you hear on auscultation? You should hear breath sound, and depending on what condition, you will hear adventitious or added sounds. Breath sound can be vesicular, bronchial, or absent. Okay, attenuated means reduced breath sound, right? So adventitious or additional sounds can be crackles or craps. We can use either or. In Malaysia, they prefer to use craps. Maybe if you work in the UK, they use crackles, or in America, they use crackles as well. So crackles can be fine, of course. I will show you an example after this. Okay. So other additional sounds are wheezes and stridor. Okay. So vesicular breath sound, you will hear the inspiratory sound longer compared to the expiratory part. Okay, I repeat, vesicular breath sound, if you hear it, you will hear the inspiratory part longer compared to the expiratory part. And then there is no gap. However, I'll tell you on my experience, I cannot tell the gap between the inspiratory and expiratory curve. But the difference between the duration of the inspiratory part and the expiratory part is very clear. Okay, so you can listen to yourself after this, right, with your stethoscope. Definitely, for bronchial breath sound, the inspiratory phase is shorter compared to the expiratory phase. So the bronchial part sounds longer, or maybe as long as the inspiratory part. So that's the difference between these two breath sound. Okay. The other part would be the character of the breath sound itself. So I'll be playing you the example of bronchial and vesicular breath sound after this. So can you please scan this QR code and listen to the. So as you heard, the inspiratory part is longer and the expiratory part should be shorter, and it should be maybe a bit quieter compared to the inspiratory part. Okay. So for bronchial breath sound, it can be caused by three C's, which is the consolidation or cavity or collapse with patent bronchus. What do I mean by this? In total lung collapse, you will hear no breath sound. I repeat, total lung collapse, you will hear no breath sound. However, if there is patent bronchus leading to the collapsed part of the lung, you may hear bronchial breath sound. Okay. So as I showed earlier, bronchial breath sounds, the inspiratory part is shorter compared to the expiratory part. Okay, or maybe in some condition, the expiratory part is as long as the inspiratory part. Okay, I need everyone to scan this QR to hear an example of bronchial breath sound. So I need everyone to scan this QR code to listen on an example of coarse crackles or craps. Okay, you may hear something. If you don't hear something, then something wrong with your earphone, I think. So you will listen something gurgling, like things popping, clop, 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 like that. So coarse craps is due to bursting of fluid bubbles. Okay, I repeat, bursting of fluid bubbles inside the airway. What fluid? It can be due to phlegm, it can be due to any fluid, it can be blood. So you will hear coarse craps. Okay. This is an example of fine crabs. Please scan it now for you to listen. Okay, so as you hear in this audio clip, the sound sounds gurgling as well, but it is softer and more high pitched. And if you notice that it occurs later in the expiratory phase, means that a bit delayed. So what does it mean? It means that the sound happens at the distal airway. So distal airway is the alveoli. So fine crabs is actually reopening of collapsed alveoli. I repeat, fine crabs is the re-expansion or reopening of the collapsed alveoli. Is different compared to coarse crabs. Coarse crabs means that fluid with bubbles inside the airway. Fine crabs is collapsed alveoli in expanding or reopening on inspiration. Okay, so next is the absence of breath sound. Always remember these three differential diagnoses: pleural effusion, pneumothorax, lung collapse, or atelectasis. Okay, so the clue is that the trachea and the heart apex beat. Okay, the clue is at the trachea and the heart apex beat. So this is when you want to look for the mass effect or the pooling effect. So I have told you earlier on trachea deviation, if there's a pooling effect, then it means that a lung fibrosis or lung collapse, if it's a pushing effect or mass effect, can be due to pleural effusion or a mass or pneumothorax. Okay. All right. Last two questions. Please look at your phone now. Answer fast to get more points. Bronchial breath sound is detected in A. Pneumonia, B. Pneumomediastinum. Sorry for the typo. C is pneumothorax. Pneumomediastinum is the air within the mediastinal space. Pneumothorax is air within the pleural space. Time's up. Okay, majority of you got it right. So pneumonia. So in pneumonia, you have fluid, you have sputum, or maybe blood in the alveoli or the bronchioles. So therefore, you will hear a bronchial breath sound. In pneumomediastinum, the breath sound should be normal vesicular breath sound. In pneumothorax, you should hear an absent or attenuated / reduced breath sound on the affected side. Okay, moving on to the next question. Skip the leaderboard. Okay, last question. I need you all to scan and listen and answer after this. So question 8, last question. What additional breath sound is it? A. Coarse crabs. B. Fine crabs. C. Wheezing. This one is quite easy lah. I don't know lah if any one of you got it wrong. Okay, majority of you, a large, answered it correctly. So it is wheezing. Hopefully the ones who answered Coscat and Finecrest had internet problem. If not, I'm a bad teacher. Okay. So as you can hear in the audio clip, it sounds like something is whistling. So that is an example of wheezing. And wheezing usually happens on expiration. Why? Because in expiration, the airway reduces in diameter or nearly closes. All right, because of the pressure and the airflow, things like that. Okay, so in patients with COPD or asthma, the degree of the airway closure on expiration is worse. Okay, so why is it that? Because in COPD or asthma, they have mucosal swelling, you have muscle spasm of the airway causing the airway to be narrowed. Okay, that's the word, narrowed. So in asthma and COPD patient, when the patient expires, the airway narrows down further, causing the whistling sound on expiration. Okay, the sound can be similar in stridor, but you need to remember stridor is the upper airway obstruction. I repeat, stridor is upper airway obstruction. So you will hear the sound better in the upper airway, which is at your throat level or at your mouth level, or maybe the upper part of the chest. Whereas for wheezing, it is the distal airway obstruction. So you should hear the sound better in the lower part of the chest wall. Okay, so stridor is upper airway, wheezing is lower airway. Okay, so all this brush sound that you heard on this lecture, I took it from Dr. Prodigious. So just search on YouTube. So they have lots of video, cardiovascular examination, the murmurs, the heart sounds, neurological examination. So please have a look at this. It's very, very, very useful and very great resource. Okay. So examination of the posterior part of the chest is similar to anterior part of the chest. So you ask the patient to sit at the edge of the bed. You put yourself perpendicular to the patient's back. Okay. So you repeat all the steps like anterior part of the chest examination. Look, feel, tap, and listen. Alright. So I won't go further for the posterior part of the chest wall examination. Last, before you complete the physical examination, if you are in clinical practice or working, do not forget to check the pyrphometer if needed. Pyrphometer, you usually use it for patients with suspected asthma or COPD. You need to check the temperature chart to look for any fever. And then if the patient has sputum pot or sputum cup or bottle at bedside, please have a look. Okay. In exam, always mention these three things at the end of your examination. Contohnya, I've examined this patient. I would like to complete the examination by doing the peak flow meter. And then I would like to look at the temperature chart to look for any fever. And lastly, I would like to check the sputum pot to look for the character of the sputum. So we are at the final step of our examination. As you all remember, the step 1 is introduction, 2 is preparation, 3 is examination, and lastly is the conclusion. So thank the patient, shake the hand, or maybe nowadays in COVID, you just put your hands on your chest, thank the patient, reposition the patient, redress as you've seen the patient during the introduction part. Okay, and then at this time, be prepared to present your findings. So this is an example of short cases that you will encounter in exam. So you can see it in the slide. I will upload it to e-learning after this. Okay, so not much, about 8 diseases only. So the take-home message for everyone, need to remember the 4 steps of physical examination: introduction, preparation, examination, and conclusion. In your examination, you need to include the general, peripheral, and specific examination. On general examination, remember the 4-3-2 rules. Okay, and during your specific examination, apply the look, feel, tap, and listen approach. And in any physical examination, always remember, always practice so that you remember the steps. Okay, and then you refine your skills better. Again, and then, or if you have the chance, always get to examine real patients and appreciate positive findings on real patient. It is totally different compared to listening or hearing or seeing online. Okay, so if you have the chance, if you encounter any patients during your attachment, please spend time listening or examining the patients.